Yes, Nandini, please go ahead.
So, a very warm good evening to the respected faculties and the Aora fellows. Welcome you all to the first national class of 2026. Today we have three topics from the basics. So, as we all know, basics is like the foundation. So, the deeper or the stronger is your foundation is, the better is going to be your outcome. So, we have three topics today, which are principles of USG, how an image is acquest, that is how we are going to acquire an image and how we are going to optimize it. And sometimes we also have these uninvited visitors, which are our artifacts. So how we are going to manage it. So we have three fellows today who will be taking us through these three discussions. And to add more points or to enlighten us more, we have our moderators. First is Dr. Hetal sir. Sir needs no introduction. Sir is the AORA academic director. Next, we have Dr. Anshuman Mishra, sir. Sir is the head of Department of Anesthesiology and Pain Medicine from Yadav Super Specialty Hospitals. Sir's area of interest are administering anesthesia for painless labor, oncosurgeries, robotic surgeries, orthopedic surgeries, and solid organ transplantation. Sir was instrumental in starting the successful liver transplant program at Apollo Lucknow. Sir has been a faculty at various national and international forums. Sir is also the member of Indian Society of Anesthesiology, Indian Society of Study for Pain, Association of Regional Anesthesiology, and Advanced Trauma and Life Support. Our next moderator is our next moderator is Dr. Pramod sir. Sir is a senior consultant from Department of Anesthesiology. Sir's area of expertise are ultrasound-guided anesthesiology, difficult airway management, obstetric anesthesiology, and anesthesia for high-risk patients. Sir is the member and fellow of the College of Anesthesiologists of Ireland. Sir is the diplomate of European Society of Anesthesiology and Intensive Care, ultrasound-guided anesthesia training at University Hospital Galway, Ireland. Sir is the chief mentor for AORA Accredited Center. Sir is the accredited assessor for thesis submission by the DNV trainers. Sir is the faculty for various conferences and workshops for at various national and international level. Sir is the editor in chief of Principles and Practice of Anesthesiology and Critical Care Pain Medicine, which is expected to be published in 2026. And we have our final moderator, which is Dr. Dilip Chavan, sir. Can we move to the presentation? So the first class presentation is going to be Principles of USG. By presenter is Dr. Prerna Bellari from Father Muller's Medical College, Mangalore. Over to you, Dr. Prerna.
Thank you, ma'am. Um,
You can share your screen.
yes, ma'am. A very good evening to one and all present here. The topic for today's discussion that is given to me is Principles of Ultrasound. My name is Dr. Prerna Bellari, and I'm an Aora Fellow from Father Muller Medical College, Mangalore. So the class will be, one second, sorry. Yeah. The class will be, this is the learning objectives. The outline would be, first we'll go through the physics of ultrasound and the piezoelectric effect. Then we'll see how ultrasound actually interacts with tissues. We'll see different probes and their applications. And finally, to just cover biological effects of ultrasound. So we'll go through the physics of ultrasound without making it too much about the physics. Just a little bit about why ultrasound has become so popular today is because it is such a safe and easily accessible point of care imaging modality. And therefore, it has been adopted into modern anesthesia practice. And all anesthesiologists must be aware of the applications and a little bit of the physics that goes behind it. So when we talk about sound, sound is a mechanical energy that moves via alternating high and low pressure waves through a medium. So the high pressure phase is called as the compression phase, and the low pressure phase is the rarefaction phase. So in clinical ultrasound, when we talk about media, we talk about air, water, body fluid, soft tissues, blood, and bone. So if I have to compare sound to make you understand how a wave propagates through a medium, it would be like a woofer that we have heard sound coming out of. So it sounds something like woof, woof, right? So there is compressions, and then there is period of nothingness. So that is, there is compression and rarefaction. So that's how a longitudinal wave appears. And that if we convert to a sine wave, this is how it would appear as a sine wave, pattern. So now that is sound. But what is ultrasound? So if I draw a horizontal line of all the sound that ever existed in the world, the actual sound that is audible to the human ear would be only between 20 hertz to 20,000 hertz. So only this sound is what is audible to us, and that is acoustic sound. Anything below that is called infrasound, and anything that is above that is called ultrasound or ultrasonic waves. So this is what is ultrasound, and that is what we are going to use. So we are going to use sound to image certain structures inside the body. Also, ultrasound works by pulse echo technique. We'll see what that means as we go through. So when we talk about a wave, we have to talk about its certain characteristics like velocity, frequency, amplitude, wavelength, so on and so forth. So first one is velocity. Velocity is nothing but the speed at which a sound wave travels through a medium, and that is determined by the density and the stiffness of the media through which it is traveling. So velocity of sound is the slowest in air or gas because it requires particles to transmit itself in the form of compressions and rarefactions. So by that logic, it is the fastest in solids. In human body, it is taken as an average of 1,540 meters per second. It remains fairly constant, the average speed of sound. Then coming to the next thing, which is frequency. Frequency is the number of cycles per second, and it is denoted by the units hertz. So ultrasound imaging frequency is commonly between 2 and 20 megahertz. And frequency depends on the source that is emitting it, and it is entirely independent of the tissue that the waves are interacting with. So it is an inherent property of the sound wave, and it does not depend on the tissue. So a low frequency would have a longer wavelength, whereas a higher frequency would have a shorter wavelength. What is wavelength? Wavelength is nothing but the distance between two peaks or two trucks. So a lower frequency will have a longer wavelength, whereas a higher frequency will have a shorter wavelength. Also, frequency relates to penetration. If the frequency of a certain wave is high, the penetration will be lower. That means we will not be able to visualize structures that are present deep inside the body. But because it compromises on penetration, it gives us a higher resolution. So resolution and penetration are inversely proportional to each other, and that depends on the frequency of the probe. So as the frequency increases, even though the penetration decreases, the clarity of the image starts to increase. Coming to the third thing, which is amplitude. Amplitude is nothing but the strength or the intensity of a sound wave at any given point of time, and it is represented as the maximum height of the wave. Amplitude decreases with increasing depth inside the tissues. Amplitude determines the brightness of the image, and higher the amplitude, brighter the image. And vice versa. So amplitude can also be, we can control the amplitude by by adjusting gain settings. So, but as the depth increases, depth of imaging increases, the amplitude is going to decrease, and the structures are going to appear less brighter. But this can be changed by us manually by adjusting the gain. Now, coming to the core principle that exists in ultrasound when we talk about ultrasound, that is the piezoelectric effect. Piezoelectric effect is nothing but a phenomenon that is exhibited by the generation of an electric charge in response to a mechanical force that is applied on certain materials. So certain elements exist in nature where they are such that if you apply electrical energy to them, they have negative dipoles in them, so they start to vibrate. And because of this vibration, there is a mechanical energy that is produced, that is nothing but sound. And vice versa also exists. So if you apply a mechanical energy to these same structures, that gets converted into a positive and a negative charge, and that is called as and that comes out as an electric charge. So that's what it is. Mechanical deformation can also be produced when an electric field is applied to such a material. What are these materials? We have quartz crystals, ceramic materials, and lead zirconate, which demonstrate piezoelectric effect commonly. So layers of such elements are stacked up in the transducer, which convert electrical energy into mechanical oscillations, which are then reconverted into electrical energy. So we will talk about the parts of the probe when we talk about a probe, but for the to start off with, the piezoelectric crystals is the footprint or the part of the probe that touches the patient. That's where the piezoelectric crystals lay. Now, we spoke about ultrasound being a pulse echo, working on a pulse echo principle. So, what is pulse and what is an echo? Pulse is to achieve a desired depth and resolution for clinical ultrasound, waves get emitted from the probe as in the form of pulses. So typically it is a millisecond in duration and it occurs up to several thousand times per second. This is called as pulsed ultrasound. So when this pulse of sound goes inside the human body, it interacts with certain tissues. And sound, when it goes and interacts with anything in nature, it reflects back depending on depending on the tissue of interest. Similarly, here also the ultrasound wave gets reflected back from the tissue and that gets converted into an electrical image. So this reflection is nothing but an echo. So echo is the waves when they travel into the tissue, they get reflected back to the probe at a rate which is determined by the target tissue's consistency. So the reflections are called as echoes and it depends on the interface of the two different materials. So, and then images get produced based on these echoes. So these echoes, some are bright, some are not so bright, some are black. So how do we term them? We term them on the basis of echogenicity, based on the color they produce on the ultrasound screen. So the more significant the echo, the more significant difference in the density, the stronger will be the echo and brighter will be that image. So structures with a high density reflect more and they are more echogenic or more white, like bone and dense foreign bodies. Fluids like water or urine or blood, they have no sound. They don't reflect any sound. Everything gets absorbed. And so they appear black or anechoic, and weak echoes appear gray. So this is the pulse echo principle in short. An electric pulse vibrates the crystal, sound waves are produced, they go and hit the organ reflects back depending on which organ or which tissue it is interacting with. So now what has happened till now, what we've spoken about is electrical wave is generated and a sound is created when a vibrating source contacts a medium. Next, what happens is electrical energy gets converted into acoustic energy using the piezoelectric crystals. The thickness of the crystal will determine the characteristic frequency of the transducer. So that frequency of the transducer is further going to tell us how deep it can focus, how clear the image is going to be, and so on. So then it goes and hits the tissues. So what happens when the waves hit the tissues is nothing but interaction of the ultrasound with the tissues, and it can get reflected, it can get refracted, scattered, attenuated, or absorbed. And depending on what has happened to the ultrasound, finally the fate of the ultrasound is decided by the tissue. It comes back and then image is formed. So we have spoken about characteristics of the ultrasound and the sound wave. We have spoken about how the ultrasound wave is generated, that is using the piezoelectric principle. Now we're going to talk about how an image is generated. So electrical signals are produced as dots on the screen, and the brightness depends upon the strength of the returning echoes, like we already discussed. And the location is going to be determined by the travel time. So we know that velocity is nothing but distance by time. Velocity we know is fairly fixed for human tissues, which is 1540 meters per second. We know the time taken, we will know the time taken for the ultrasound wave to go and come back. Based on that, we will get distances. So we distance, and that is plotted as different points on the ultrasound image. So we are able to produce images because the velocity of sound is fairly the same, and hence the distance can be inferred from the echo return time. So this is how it will appear. If it has traveled a shorter distance and it has come back faster, it will appear superficial. Whereas if it has traveled, it has taken a longer time to come back, we infer that it is at a deeper location. So the image can be displayed in three modes, that is A mode, B mode, or M mode, that is amplitude, brightness, and the motion mode. In ultrasound guided regional anesthesia, the most common mode is the B mode. So now coming to how ultrasound interacts with tissues and what happens to it. And so this is 5 main things that happen when we talk about interaction. There's reflection, refraction, transmission, scattering, and attenuation. So coming to the first one, which is reflection. the ultrasound waves are reflected off of the tissue and they return fully to the transducer. But how much gets reflected, that is decided based on the difference in the acoustic impedance between the two media. So if the media impedances are equal, there will be no echoes, there will be no reflection. Well, that is one thing. Second, the reflection also depends on the angle of incidence. So we'll talk about what angle of incidence is and what acoustic impedance is. So, but this is how ultrasound reflection is. From soft, when waves pass from air to soft tissue, the difference in the impedance is very high. So there is a large reflected signal. Similarly, when waves travel between soft tissue and bone, again, the difference in impedance is very high. So we get very strong echoes. So what is angle of incidence? It is the angle at which ultrasound waves engage with any structure. And structures will be best visualized when the angle of incidence is at 90 degrees to the emitted waves, because echoed waves return to the probe in the greatest concentration. So when waves interact with the structure obliquely, few echoes come back to the probe, few are lost, and that decreases both the brightness and the resolution. Coming to acoustic impedance. Acoustic impedance is basically resistance. So resistance to what? Resistance to sound. Resistance of a tissue to the passage of ultrasound is the acoustic impedance. Higher the degree of impedance mismatch, greater will be the amount of reflection. So for air, the acoustic impedance is almost 0.0004, and that is very high compared to the rest of the tissues. So that's why there's a high degree of reflection that happens from air. So that's why it is important in clinical practice that we use a good coupling medium like conducting jelly in between the probe and the skin. Otherwise, all the ultrasound that comes out will get reflected even before it gets penetrated into the human body. So this is a small video that I wanted to show about how important it is that the ultrasound probe remains at 90 degrees to the structure we are imaging. So this is the waves that are transmitted from the ultrasound transducer. We'll see that some of it gets reflected, some gets absorbed depending on the tissue. But at 90 degrees, like it is seen now, most of it comes back to the probe. So we will be able to visualize it better. But if it is kept at a certain angle, what happens is when the waves get reflected, they get reflected away from the probe and we will not be able to see the image very clearly. So that is why angle of incidence is important to know. Now, second thing that happens is refraction. So refraction is when an ultrasound beam passes at an angle other than 90 degrees from one tissue into another with a change in velocity. So this increases with increase in the angle of incidence, and it passes deeper into the body, which gives rise to artifacts. So ultrasound refraction will occur when the velocity of sound in between the two tissues is different. So when sound wave passes from a medium in which the speed is faster to a medium in which the speed is slower, the sound appears to have bent, right? So that is called as refraction. And we assume that the ultrasound actually travels in a straight line, and when it does not, that gives rise to artifacts. So the degree of this beam change is dependent on the change in the speed of sound traveling from one medium, that is the incident medium, to the transmitted medium, and this is the Snell's law. So in medical imaging, fat causes maximum refraction and image distortion, and that's why we find some difficulties in imaging obese patients. Refraction, like I said, is a source of artifacts in ultrasound, and ultrasound machines operate under the assumption that waves always travel and return in a straight line, but that is not always the case. Right, so this is if while imaging the rectus sheath, it sometimes appears like there are two deep inferior epigastric arteries, and that can be attributed to refraction. Coming to the third thing, which is absorption. Absorption is when the sound travels into the human body, some sound gets absorbed into heat and it gets dissipated as heat. And ultrasound scanning generates heat in tissues. We know this. Higher frequencies get absorbed at a higher rate. Lower frequencies get absorbed at a lower rate. So the tissue that absorbs the highest ultrasound waves will also have higher attenuation. So what is attenuation? We'll see later. Scattering is nothing but redirection of sound in different directions by any heterogeneous media or rough surfaces. So scattering intensity is not like our mirror image reflection, and it is not that intense. It is relatively independent of the direction of the incident sound wave. So it does not depend on the angle of incidence. But our visualization of target nerve is not significantly influenced by the nearby scattering that's happening because of with the other tissues. So what is attenuation? Attenuation is the sum total of reflection, refraction, scattering, and absorption. And what it does is it leads to a loss of clarity of the image. So when waves get scattered and energy gets absorbed, it results in vibration and heat. And all of the processes that contribute to energy reduction from the probe are collectively referred to as attenuation. This is measured in decibels per centimeter of tissue, and it gets denoted by attenuation coefficient. So a reduction of 3 decibels corresponds to a decrease of the original intensity of the ultrasound wave by half. So higher the attenuation coefficient, more will be the attenuation of the ultrasound wave by the specified tissue. For example, bone has a very high attenuation coefficient. So all of the waves that come to the bone, they get attenuated and nothing is transmitted beyond the bone. That's why there is a shadow when we image a bone. There is a shadow beyond the bone, and we will not be able to see anything deeper to that. Attenuation is also determinate of the depth of penetration. It is directly proportional to frequency. If it is so, more the frequency, more the attenuation. And penetration is inversely proportional to frequency. We know this also. So if the frequency is more, it will not get penetrated more. So that's what I'm trying to say is when the frequency increases, the attenuation increases, and therefore there will be not much penetration into the tissues, and therefore high frequency ultrasound beams are very useful for visualizing superficial structures. So if the frequency is high, attenuation is high, and it will not get penetrated. So we will only be able to see the superficial structures. Coming to gain. Gain is the ratio of output to input electric power, and it controls the brightness of the image. Increasing the gain, of course, amplifies the strength of the echoes, but it also increases the background noise in the system. So there is a concept called time gain compensation, which is a time-dependent amplification, and this function can be used to increase the amplitude of incoming signals from various tissue depths. So if we see, this is scan of the median nerve in the forearm. The first image is that of appropriate gain, where the median nerve appears brighter than the surrounding non-neural tissue. The second image is that of overgain, where everything appears white. And the third image is undergain. So there is some machines have time gain compensation where we can increase and decrease the gain based on what structure we are imaging and at that tissue depth. Now coming to image resolution. Resolution is the ability of the ultrasound machine to distinguish two structures. They can be either reflectors or scatterers. So two structures that are close together, but the ultrasound machine can tell them separately from each other. So when we talk about image resolution, we talk about spatial resolution, which determines the degree of image clarity. And spatial resolution is of two types, that is axial resolution and lateral resolution. So axial, as the name suggests, is the ability of the system to display small structures along the axis of the beam as separate from each other. And this is proportional to the frequency of the ultrasound beam. Whereas lateral resolution is the ability of the system to display small structures side by side in the same plane at the same depth as separate from each other, and this depends on the width of the ultrasound beam. So when we talk about resolution, there's a concept called focal zone, where all the ultrasound beams, they have a narrow beginning shape, and then after a certain point, it diverges. So at this point where it diverges, two fields are created, that is a near field and a far field, and the point where it converges is called as the focal zone. So it is at this focal zone that the best resolution takes place, both axial and lateral. And the depth control allows the operator to focus the beam so that our image of our structure of interest comes to lie in the focal zone, and it gives us the best resolution. So now coming to echogenicity, how do we describe different structures when we talk about ultrasound? Is based on echogenicity, right? Based on the echoes that they produce. So they can be isoechoic, that is the structure is the same brightness as that of the surrounding tissues. It can be hyperechoic, where that structure that we are visualizing is brighter. It can be hypoechoic, that is it is dark but not black. And it can be anechoic, where it is completely black and no echoes are being reflected back from such a tissue. So different tissues appear different in the ultrasound, and that gives us that's what makes it an image of black, whites, and grays. So coming to the first two, which is veins and arteries, both of them are anechoic because they contain blood. Only difference between them is veins are compressible, whereas arteries are pulsatile. So this is an image of a vein which will compress easily with our probe pressure, whereas artery will not get compressed. Instead, it will remain pulsatile. Then coming to fat and muscles. Fat appears hypoechoic with irregular hyperechoic line. Same muscles are also heterogeneous, but and they have a mixture of hyperechoic lines with a hypoechoic tissue in the background. So if in this image, the superficial structure is fat and the deeper structure is muscle, the striations in the muscle are more longitudinal, they are more regular as compared to that in fat. Then coming to the difference between tendon and nerves, tendons are hyperechoic and so are nerves, but tendons have a fibrillar appearance, whereas nerves have a more honeycomb appearance. Right, so this is a cross section of a nerve. Here, this is on the left side is the cross section of a nerve, whereas this is a cross section of a tendon, and the bone appears white because it is hyperechoic, reflects everything, and rest of the beam gets attenuated, so it has a hypoechoic shadow. So this line is how a bone would appear on an ultrasound scan. Now coming to probes, ultrasound probes or transducers, what are they? They are instruments that emit and receive ultrasound waves by way of electrical signal conversion to sound waves, right? So ultrasound transducers contain the piezoelectric crystals. So we know what the piezoelectric crystals do now is that when electrical impulses are applied to them, they produce waves. What sort of waves? What is the frequency of this wave? That is determined by the crystal's propagation speed divided by the thickness of the crystal layer. So that means the frequency will be decided by the denominator. So if the thickness is more, the frequency will be less. And if the thickness is less, the frequency will be more. Coming to parts of a probe, it has 7 major parts. We have the housing case, the electrical shielding, the acoustic insulation. What is most important to know is that there is a piezoelectric crystal, which has a backing material at the back, acoustic lens in the front, and a matching layer in between the crystal, in between the crystal and the lens, actually. So the piezoelectric crystal produces ultrasound waves. What acoustic lens does is that it focuses this beam. The matching layer, it actually decreases the impedance, and so it improves the transmission of the ultrasound waves. What the backing material does is that it prevents stray vibrations, and if the it makes sure that the waves are getting transmitted ahead. So it is made of a acoustic damping substance, and so it damps all the unnecessary vibrations, right? So it dampens the vibration, it stops it from ringing, produces shorter pulses, make sure that the energy gets transmitted only forwards. And acoustic matching is done for optimal energy transfer, and it also protects against damage. This whole thing is covered by a protective casing. Now, coming to how do we choose the right probe? The typical thickness of the crystals is between 0.2 millimeters to 2 millimeters, and the bandwidth of a probe is the range of the frequencies in which this probe is going to operate. So the frequency of the scan head, like I said, will be determined by the thickness of the crystals. A thin element will produce higher frequency. A thick element is going to produce lower frequency. The pulsatile nature of the wave produced facilitates emission and reception of the sound waves by the probe. So when the incident pulse reflects off of tissues, it produces echoes. This ultrasound transducer can detect the strength, direction, and the timing of arriving echoes. Now, the number of pulses that are produced in a single second is the pulse repetition frequency. So we have one pulse, and how many such pulses are produced in 1 second is called as the pulse repetition frequency. And pulse repetition period is the time between the start of two pulses. Okay, so in between two pulses, the time taken is the pulse repetition period. Whereas how many pulses are produced in 1 second is the pulse repetition frequency. Why should we know this? Is because let's assume the pulse repetition frequency is 5 kilohertz. The time between the pulses is 0.2 milliseconds. What that means is it will take 0.1 millisecond to reach the target and 0.1 millisecond to return to the transducer. So we know, we've already said velocity is distance by time. Here we know the velocity of sound in tissues, which is 1540 meter per second. And 0.1 millisecond is the time taken for it to return to the transducer. So if you multiply, you will get 15.4 centimeters. That is the distance. So a pulse repetition frequency of 5 kilohertz will travel a distance of 15.4 centimeters before the next pulse is emitted. That means pulse repetition frequency and the period are inversely related to each other. If the frequency is more, the time in between the two pulses will automatically reduce. So higher pulse repetition frequency will have greater image resolution. But because the distance is low, the depth is shallow. So that's what it is. So high frequency will give us a great image, but it will not go too deep because of the distance traveled will be less. Whereas in a higher pulse repetition period, meaning if the frequency is low, then this increases the listening time of the transducer and it will allow the sound to go to a greater depth and come back. So that's why with a lower frequency probe, we will be able to visualize deeper structures. So commonly used probes in practice are linear, curvilinear, and phased array probes. And the footprints of all these three probes appear different. Linear is rectangular, curvilinear is convex shaped, and the phased array probe has a square-shaped footprint. So the linear transducer is also called as the vascular probe, and the frequency it operates in is between 4 and 13 megahertz. And the piezoelectric crystals send the ultrasound waves parallel to each other in a straight line. So only in this plane will we visualize the images, and it has high frequency, so the depth is low. Coming to the phased array, before the phased array, we will see the curvilinear or the convex array probe, also called as the abdominal probe, best to visualize the abdominal structures and for obstetric and gynec scans. It's a low frequency probe, so operates between 2 to 5 megahertz, and the crystals are arranged in a convex shape. So the image that we see is quite wider than when we compare it to a linear transducer. Now coming to a phased array probe, this also operates at lower frequencies at 1.7 to 4 megahertz, so almost 2 to 5 megahertz. But this is called as a cardiac probe because how is the cardiac probe or the phased array probe different from the other two crystals is that the crystals are not arranged in a line or in a convex manner. They're arranged in the form of a grid containing 64 to maybe 128 crystals. And the speciality of this is that each crystal vibrates at a different time from each other. So it appears as in pulses to give so it is used to visualize any structures in motion. So that's why it is called as a cardiac probe. Unlike the linear and the curvilinear probe, where all the sound waves are emitted at the same time, here it will be emitted one after the other at a certain time period. Right, so that's why it appears in phases. That's why it is a phased array probe. So to put these three together, like I said, the piezo crystal arrangement in a linear and curvilinear would be in a line, either straight line or curved line. But in a phased array probe, it is in a grid or linear or curvilinear pattern. And the image obtained will be rectangular in a linear transducer. It will be fan-shaped in a curvilinear transducer, but it will be a sector-shaped image in a cardiac probe. And frequencies, linear transducers is a high frequency probe, curvilinear and phased array transducers are low frequency probes. So the applications of each probe is different. Linear, we will use for soft tissue, musculoskeletal, pediatric, ocular to image the trachea, the thyroid, and for most procedures in regional anesthesia. Curvilinear is used to visualize the aorta, the IVC. It is used for EFAST and FAST for abdominal and obs-gynae scans. And phased array probe is used. So curvilinear can also be used as a phased array probe. It's just that because the footprint is so big, it will not fit in between the ribs and we will not really be able to visualize the cardiac structures too well. So the phased array probe is used for cardiac structures, can also be used for the same things that a curvilinear is used for, that is abdominal, EFAST, IVC assessment, and bladder bowel scanning. Now to touch up on the last part, which is how we know that it interacts with tissues, but it also leaves certain effects behind, which is categorized as the biological effects of ultrasound. Why does it have certain effects? Is because it is a mechanical energy, so that is going to transmit some effects. For most practical purposes, we know ultrasound is safe, but it also has certain effects that we should know about, which is classified into thermal and non-thermal biological effects. So the thermal effects give rise to tissue heating, and the non-thermal or the mechanical effects relate to cavitation, radiation force, shear stress. Both these effects can occur simultaneously during scanning, and the safety is assessed or it is quantified by the thermal index and the mechanical index. Okay, so thermal effects is because of absorption of the energy which gets converted to heat, and how much the temperature rises depends on the acoustic intensity, the frequency, the exposure time, and also the tissue characteristics. That is, bone, eyes, lung, intestine, they absorb a lot of heat, and so those are more susceptible for thermal effects. Also, the fetal tissues, especially in early gestation. It is quantified using the thermal index. The non-thermal effects are more relevant at a higher acoustic pressure, low frequency, or if there is some gas microbubble, especially when we use contrasting agents. And it includes cavitation, acoustic radiation force, acoustic streaming, microstreaming, shear stress, and membrane permeability changes. And it is quantified using the mechanical index. So both the thermal index and the mechanical index will be displayed on the top right corner of our ultrasound screens. Thermal index is an estimate of the potential temperature rise in the tissue because of ultrasound exposure. It is the power required to raise the tissue temperature by 1 degree Celsius. So it is not the actual temperature rise, it is a relative risk indicator. And a higher TI would mean a greater potential thermal hazard. Right? So thermal index ranges from 0 to 5. So the FDA has approved certain guidelines where it says a thermal index of less than or equal to 1 is considered safe for prolonged scanning. If it is more than 1, then the exposure time should be limited and definitely should not be more than 6. But when we are doing ophthalmic ultrasound, it should not exceed 1. So similarly, mechanical index indicates the likelihood of cavitation-related bioeffects. So it reflects bubble oscillation or collapse. Any bubbles that can be formed inside blood vessels, especially, would be dangerous, and they can go on increasing and then rupture. That's because of the shear stress that the waves are producing on small structures. Cavitation is unlikely, and the risk of mechanical damage increases at lower frequency with a higher pressure amplitude and in gas containing tissue. So this is how. So it's a small bubble, it goes on increasing, and then it can also explode at an index of more than 1.9. So the maximum allowable according to FDA is 1.9. With contrast in agents, the threshold is lower. It is at zero point 0.4 to zero point 0.7. And if we are scanning the neonatal lung or intestine, it should not be more than 0.3. Certain other biological effects observed were an effect on the molecular and the cellular level, which is there's increased incidence of reactive oxygen species, increased membrane permeability. There can be DNA fragmentation and heat shock proteins. However, this was not seen in there was no effect seen in humans. Same, there were no genetic effects, proven effects seen in humans. And fetal mode, B mode, has no proven long-term harm. The Doppler and with prolonged scans, there can be an increased thermal risk, and early gestation period is more vulnerable. So what we can do to reduce this is go by the Alara principle, which is as low as reasonably achievable. So what that means is we have to use the lowest power possible, monitor the thermal index and the mechanical index continuously, limit dwell time, and avoid prolonged stationary scanning. We have to be a little more cautious in pregnancy, neonates, eye, lung, brain, and bone interfaces. So this is an AI generated image. That is an infographic of the biological effects of ultrasound. In short, that is heat and mechanical. Thermal index is of three types: TIS, TIB, TIC. TIS is thermal index for soft tissue, TIB is for the bone, and TIC is for the cranium. That is when we are scanning for the fetal head scanning. So less than 1 is safe, more than 1 caution is recommended, and more than 6 is not recommended. Similarly, mechanical index risk levels less than or equal to zero point 0.3 caution for neonates, for more than 0.7 cavitation risk with contrast agents, and 1.9 is the FDA limit. So bone, eye, fetus, and lung have a high propensity for developing thermal effects. And when we talk about non-thermal effects, we talk about cavitation and stress, that is microbubbles, radiation force, and cellular effects. Certain observed things are cell damage, DNA fragmentation, microvascular injury, and hemorrhage. So prevent this by using the Alara principle. These were my references. Thank you. Should I stop sharing my screen?
Yes, please, Prerna. Purva, you have to optimize it a bit.
Good evening, everyone. I will be presenting the image acquisition and
Can
optimization.
go.
Yes, ma'am.
Go ahead.
Continue, Dr. Purva.
Okay. So, the objectives for my presentation will be to optimize the machine settings for high quality ultrasound images, apply a structured approach to image acquisition and troubleshooting, optimize needle visibility with probe and needle strategies, incorporate adjuncts such as Doppler, triple monitoring, and AI, and reduce complications that are anticipated with performing a nerve block, appreciate any emerging tools such as AI that may support an image optimization. So I will divide my presentation into two parts. Part one, which will deal with the ultrasound image acquisition and optimization, while part two will deal with needling strategy, needle visibility, and safety of while performing nerve blocks. So why is it important to have a very high quality image in regional anesthesia? So, human interpretation at all times is imperfect and it can result in a lot of errors. But image quality and training are generally the limiting steps that we face while we are performing a successful and safe nerve block. So, if we have a bit better image quality, we have a higher success rate of performing a nerve block, we use lower LA doses, and we have fewer complications. While a poor image would result in more complications and higher block failures. So, adequate visualization does not only incorporate visualizing the nerve, it rather also incorporates visualizing all the structures that we must not hit, the neighboring vessels, the pleura, and also monitor the spread of local anesthetic and make your nerve block absolutely safe. To start with, let's see how we should actually be dealing with the probe and the monitor. So the whole art of understanding the alignment of the probe, the patient, and the working environment would be known as ergonomics. So it will if we do put our transducer, the operator, and the monitor in one straight visual axis, we can reduce operator fatigue and also improve and also avoid work related musculoskeletal discomfort. While if we are probably turning our head or using different movements to kind of gain that access to the image which is being showed on the ultrasound monitor, we are going to end up with more musculoskeletal fatigue and probably cause discomfort to ourselves or the patient. So we can use this principle, which says ALVA, which is to align the line of visualization axis, where the ultrasound probe and the needle and the long axis are parallel and in the same visual plane as the ultrasound. So, mostly what we should do when we're performing an ultrasound guided nerve block is to maintain a neutral, aligned, and supported posture with proper machine and monitor positioning, maintain a clear visual axis. We should not allow any hand crossing, use only our dominant hand for needling, and also place the probe in the relaxed hand, which is rested onto the patient's body, improve precision, and minimize fatigue. So likewise, when we're handling a probe, we are already doing that. We're handling it with a non-dominant hand, using a hypothenar aspect on the patient, keeping it on the patient's body, and using that to gain stability and control, and thereby ensuring precision and minimizing fatigue. So when we already in the previous part of the presentation, the probe and the probe selection has already been discussed with utmost beauty and detail. So I will just touch upon it to tell you that whenever we are performing our nerve blocks, for superficial blocks, we would choose the linear high frequency probe, while for a deeper seated nerve, we would go for a curvilinear probe. Now, the phased array probe is primarily used for focus. So, considering I will be discussing on image acquisition, I will primarily focus on the linear and the curvilinear array probes and their optimization. So once we have decided, what nerve block we wish to perform, and we have selected our probe, which is the curvilinear and linear, we will then select the correct preset, whether we want to scan for a nerve for any musculoskeletal area of interest or the vascular. So by doing so, the ultrasound machine already has this optimization feature where it would optimize the frequency while balancing the resolution and
Dr.
penetration.
Chiranshi, can you mute yourself? Yeah, please go ahead.
The machine will itself optimize focus and place the focus at the targeted nerve depth, and also it will incorporate certain imaging processing modules whereby improving the contrast of the image, allowing edge definition and reducing the noise of the ultrasound image. So firstly, selecting your exact preset is very important. So when we are selecting the probe, so what are we exactly wanting to achieve? So already it's been discussed, and a lot of stress has been placed on the axial and the lateral resolution. So the whole idea while we are choosing our probes is, if you're choosing a high frequency probe for a superficial structure, we are basically improving our axial and our lateral resolution while kind of, giving away and trading off penetration. While if we're choosing a low frequency probe, we are getting a deeper penetration but a lower resolution. So when we do talk about a high frequency probe, what are the features of the high frequency probe that practically help us in getting a better image? So already the working principle of the linear frequency probe has been discussed. So now what really happens is that in a high frequency probe, we have sequential excitation of crystals. So what that does is, when it moves it scans the image from one end to the other in a sequential, because of sequential excitation of crystals, and thereby incorporates all those images, smaller images that are formed into building one large image. So when it is allowing that sequential excitation of crystals, it is producing an excellent axial and a lateral resolution. Also, a linear frequency probe uses a principle of beam steering. Now, this beam steering will basically depicts that when your sound beam is not just directed in one direction. So when you do keep your transducer in one direction, the beams that are produced from the transducer can be in multiple directions so as to gain the image from all angles, and thereby giving you a very beautiful image with lesser contrast, lesser speckle, and allow almost all minute details to be caught by this principle of beam steering. So normally what happens is that it's commonly known that the linear frequency probe is only going to give you a rectangular image. But a lot of our newer machines have a function where we can even gain a trapezoidal image that is basically gaining a wider field of view. So the same linear frequency probe that we use in pediatrics or in an area of interest where we have probably limited space to scan a wider area, then we can use something called as a hockey stick probe, which is primarily used in pediatric regional anesthesia. It has a very small footprint of 25 to 26 millimeters. So this is an image of a trapezoid view obtained from a linear probe where I'm trying to focus on the median nerve. But when I made it into a trapezoid image, I could also see certain vessels around there, thereby increasing the field of view. So now moving on to the curvilinear probe, it is very similar in its mechanism of as a linear probe. It also does work with sequential element excitation, but the difference is that the ultrasound beam is emitted perpendicular to the surface of the curve. So basically giving us a very large trapezoidal field of view. So now this wider field of view gives us better access to depth, thereby increasing the penetration and allowing us to perform nerve blocks where the area of interest is seated a lot deeper. Now, this beam divergence that happens at depth has certain fallacies also. It is giving you better penetration, allowing you to look deeper, but it has certain fallacies. It will reduce the line density, which I'll be discussing in the subsequent slides, is an important function to have. And also, it will decrease the lateral resolution at deeper levels. So you might not be able to differentiate between two objects which are placed very close together. So this is a summary of what I just discussed and has already been discussed before. Primarily choose a high frequency probe whenever you want a better axial and lateral resolution, and for superficial structures with a low frequency probe for better tissue penetration and deeper structures. Second, we move on to the presets. So like I mentioned, either you can set the preset by the modes that are already present in your ultrasound machine. A lot of them are even kind of we even have further sub demarcations of those where we can choose for shoulder, knee, and other different parts of the body. Or we can actually, once we have kept the probe onto the patient, we also can change the presets on our own and change all of these settings one by one to gain the best possible image and to assist needling and performing a nerve block. So the first one that you should do, which is the first parameter to optimize, is the depth. So the depth will depend upon the block that you're performing and the patient's habitus. So whenever you select an appropriate depth, you are ideally increasing and optimizing the area of focus and improving the image resolution to the area that is the area of interest. So you have to ideally choose the smallest field of view where you can see the target nerves and the adjacent safety structures like the pleura and the vessels so as to avoid them during the nerve block. So a shallow depth will give you a better temporal resolution. And temporal resolution is very good because it's going to detect almost all the motion that is going to be happening in that small field of view. So the depth should be just enough to see both the nerve and the danger zones. No more, no less. So this small function is going to be present in all our ultrasound machines at different areas. And we can increase or decrease the depth and it will be seen in centimeters on the side of the screen. This is a table of routinely performed nerve blocks and the depth that has been ideal for most patients. So if you want to do any superficial blocks, you can even get away with a depth of less than 2 centimeters. While if you want to go for deeper blocks like that of a sciatic nerve, then you would probably have to increase the depth to 10 or even more, depending on the habitus of the patient. Second would be to adjust the gain. So once you have the depth in view, now you would want to see the structures. So you can increase the brightness. So gain is nothing but the screen brightness essentially. So it has a similar effect as the power, but there is a lot of difference. The gain will amplify only the electronic signals produced by the returning echo, while the power generally does so of the transmitted wave that is going into the tissue, thereby increasing the thermal index and the mechanical index, while this is a post-processing control. So this only increases the amplification of the returning echoes. So we can either increase the overall gain, or we can increase gain only in a part of the image. So in case we do increase the overall gain, our image is going to look something like the image on the right. If you increase it too much, this is overgain. So if you notice here, we've lost contrast and we have a very noisy image. While if you look to the left, we have a very undergained image because we cannot really look at the structures or discern the boundaries of any structure here. This is the image in the center shows optimal gain. This particular image basically is showing you a liver and the gallbladder and the demarcated wall of the gallbladder very well. So the optimal gain setting would be to have the best contrast between the muscle and the connective tissue. And the connective tissue and the nerve echo texture should never appear the same when you have optimal gain in place. Next, we come to time gain compensation. So when we're discussing time gain compensation, it's already been discussed with exactly the mechanism behind it. So I'll just tell you what we should do practically to get the best image. So you can see the left side, these are the lines, and we need to basically adjust them from the near field to the distant field. So usually we should adjust them with the near field gain turned down and the far field gain turned up in steady progression to adjust for beam attenuation at depth. So we already know that the beam is going to get weaker as the depth increases. So we can actually only amplify the bottom signal and visualize the deeper structures better. Now, time gain compensation and gain both require frequent readjustments because different tissues will attenuate sound differently, and we are going to constantly move the probe. So once you have your final image in place, after that, you probably don't have to move your gain settings at all and use the fixed gain settings to conduct your nerve block. So focal zone has already been discussed. So I will just discuss the practical aspects of what we are wanting to achieve when we are discussing focal zone. So when we talk about focal zone, it is almost synonymous to saying that a good focal zone is going to give you a good lateral resolution. So lateral resolution is important to us because we need to differentiate between two very closely placed structures, and they should not appear as one. We should not have any missed details. So primarily, we are going to use a high frequency probe and place our area of interest within this narrow part of the beam, and thereby it will be at the area where we are going to have the best focal zone. But there is a problem with focal zone. So when you have a focal zone, and you can, in a lot of machines, you can set multiple focal zones. Suppose if you have an area of interest right at the top and the middle and the bottom that you want to visualize with utmost clarity, you can select more number of focal zones. When you do that, essentially what happens is the image that is the time basically taken by the ultrasound to form each of these images is going to be slightly longer. So the ultrasound machine has to work a lot harder. So it basically trades off one thing. It reduces the frame rate because it's taking a lot of time to generate each of those images with utmost clarity. So what happens is the frame rate will decrease, and when the frame rate decreases, so does the temporal resolution. So when you're needling, that's not a very good thing because sometimes the needle movement is not exactly in real time at that point of time. It's probably like a microsecond historical at that point of time. So like I said, you have a function of multi-level focusing, and in a lot of our machine that happens almost automatically. We really do not have to focus it. There is a button called autofocus. You press on it and it results in multi-level focusing in a lot of machines. So basically multiple pulses are transmitted at different depths, and that all of those pulses are then combined to form a single image, which is very beautiful to look at. But the consequences are that we get a decreased frame rate, the image will lag behind to what is really happening in the body, and we will also have reduced shadowing. The next thing that we need to touch upon is the field of view. So now that we've adjusted the depth, the gain, and the focus. Now we want to see if our field of view is adequate. So all the structures that we wish to visualize should be present in a single field of view. So the image size is basically, or the field of view is comprised of two parameters, one being the depth, one being the width. Now in a linear frequency probe, we mostly have a rectangular image where, while in the curvilinear, we have a trapezoidal image. So now if you see on the right, we have the infraclavicular fossa, which has been imaged by a linear and a curvilinear probe. You see that more structure and the surrounding area is visualized with the curvilinear probe because we have a larger field of view. While with the linear probe, we have a smaller field of view and a smaller area of interest has only been visualized. Now, again, here with ultrasound machines, there's always a trade-off. If you get more of something, you will always get less of something else. So when you get a large field of view, you're going to have a slower frame rate. While if you have a small field of view, you're going to have a higher frame rate, which means a large field of view might again take longer to form an image. Again, the image might be slightly historical. So next, moving on to line density. So the ultrasound image is ideally not formed in a very continuous fashion. It is constructed line by line, superimposed one on top of the other, and these lines are made independently by independently fired crystals. So line density simply means how many scan lines are used to build one single frame. So when you do increase your line density, you are actually improving spatial resolution, thereby improving lateral resolution, because you're getting a very beautifully defined line. Thereby, you can basically differentiate very close together structures. But what really happens is when you have a very beautiful appearing image with very crisp lines, you actually do trade off frame rate again, because any image that is more beautiful to be formed is going to take a lot longer to form. While if you have a low line density, you will have a higher frame rate, whereas frame rate would basically mean you do not miss anything in motion. So if you see here to the left, we have a very crisp line. This is basically an IVC that's being formed. And if you see the posterior wall of the IVC, you see a very crisp line here. While on the right, you will see a slightly pixelated line. So the first image is showing you high line density, while the second one is showing you a lower line density. But the second one might probably be important in case you have a vessel. Suppose if it was a IJV and you wanted to cannulate it, I would probably prefer the second one because I can then see my needle in real time. The next feature that you should optimize or you should check upon go and perform your nerve block would be dynamic range, which is also known as compression. So now dynamic range describes how wide a range of echo strengths the machine can display, from the weakest to the strongest, and they would all appear as shades of gray. So this is basically achieved that by compression of signal amplitudes. So what we mean by high dynamic range is that there is minimal compression of all the signals that have been received. So small differences in echo strengths are preserved and you will see many shades of gray. So the image would look a lot smoother, softer, and more nuanced, but with very little contrast. So basically, this dynamic range is essentially the contrast dial of your ultrasound. While a low dynamic range would completely form an opposite image, a high contrast image with more black and white, but not many shades of gray and sharper edges. So if you see here, the bottom image shows you a very low dynamic range. So you can see only white and black, and you can see a very crisp image with a very high contrast, kind of jarring to the eyes. Second one is optimal contrast. So that is the optimal dynamic range we would go for. So you would not miss any finding, but at the same time, the image does not look jarring to you. The third one is a very smooth image. It is important in diagnostic ultrasound to get such an image because you do not miss any of those gray speckles. But when it comes to needling, you can get away with probably the second image. So this is an image of the median nerve that we took in our ultrasound, and we set the dynamic range to +3 because the Philips sonocyte allows us to set it in ranges of 0, 1, 2, and 3. So that is the maximum dynamic range that our ultrasound allows us to have. And then we see this very smooth image. While on the other side, when we have the dynamic range set to 0, we see a slightly gritty, high contrast image, but smoother lines and extremely bright. The next function you want to check if it is on or off is tissue harmonic imaging. So tissue harmonic is an interesting concept because it works because the ultrasound beams are not traveling only in a linear fashion. So what happens is that the wave gets propagated, it gets distorted. And the distortion by the tissues actually creates new frequencies that are sent back to the ultrasound. Now let's just assume that the first wave that was sent out by the ultrasound was X. So the second frequency that was generated within the tissue, but that was sent back to the probe, will be an integer of that X, like 2X, 3X, 4X, or whatever. Now, this frequency will be picked up by the ultrasound probe, while the original fundamental frequency that was given out by the ultrasound probe would not get picked up again by the ultrasound probe. So this gives us an advantage. We are only getting the returning echoes back to the ultrasound. So this will reduce any artifacts. It will reduce reverberations and side lobe artifacts. It will improve the clarity and contrast of the image because this is literally communication with the tissues. And it will give you better penetration, lower noise, and better signal to noise ratio. Now, one interesting concept is probably it will be discussed later is side lobe artifact. So I'll just touch upon it. So that occurs when there is some beam that is being reflected onto an object which is not exactly lying in the area of the main beam. So it is also going to get superimposed and form an image. But when you turn on harmonics, what really happens is that harmonics only picks up the returning echoes from the main beam. So it basically can reduce all the structures that are on the side that are basically going to form an image because of scatter. So thereby you're going to get lesser artifacts, crisper image, and a safer area to perform your block set types. So harmonics also generally functions best in the midfield. So not in the far field, not in the near field, but it can also go up and improve the signals from the far field. So this is again the same image of the median nerve with harmonics turned and harmonics turned off. When you look at harmonics turned on, you see again a beautiful image with less contrast, but with finely defined lines. While here you have harmonics off, you see a slightly gritty image as compared to the other one. Now, compound imaging. This is also a function which you can manually turn on and off in certain ultrasound, but in ours, in the Sonoset, it's already turned on automatically. So, compound imaging means that the machine is not looking at any one tissue or any one structure from only one direction. But what it does is it looks at every structure from multiple different directions, and then it averages all of these images that are being formed from multiple directions into one single image. So now compound imaging is of two types. We either have spatial compounding, which means that the multiple frames that are generated from beams that are being sent out at different angles, or we have frequency compounding, which means that you combine the images that are being produced by two different frequencies by the same ultrasound probe. So the first one is actually going to improve your contrast, and it will also reduce angle dependent artifacts, while the second, which is the frequency compounding, will reduce speckle and cluster, and it'll make your image look a lot smoother. So it'll reduce noise in your image. So every time there's a trade-off. When you make your image look a lot better, what really happens is you reduce your frame rate. When you reduce your frame rate, the problem is that you need to see your needle moving in real time. You might have poor needle visibility. So whenever that happens, do not blame the needle or your needling technique. Sometimes just check your machine settings to see if compound imaging, tissue harmonic imaging, and other such features have been turned on. So maybe we can scan with all of these features turned on, but when we're needling, we need to check if there is really a lag, which nowadays in most of our machines is not there. We can probably turn it off. So this is a structure with conventional imaging versus compound imaging. So if you see in conventional area of interest, while in compound imaging, we have beams that are being thrown in all sorts of directions. So what that does is that gives you a very well-defined structure image with better borders. So this is basically a liver with a hemangioma sitting right in the middle of it. So the hemangioma is seen well demarcated in the second image, while it is kind of in flush with the liver parenchyma in the first image. Next, we must always use Doppler ultrasound, because Doppler ultrasound is going to help save us from injuring any vascular structure that comes in our field. So just a little bit about the basic principle of Doppler. So what happens is that there is a change in frequency or wavelength of sound wave, which results from relative motion, which is between the sound source and the sound receiver. We're not actually detecting the vessel, we're detecting the movement of blood within the vessel. So whenever the flow is towards the probe, we get a positive Doppler effect, which is there is a high frequency shift. While when the flow is away from the probe, it's a negative Doppler shift. And whenever there is a faster flow, we will get a bigger Doppler shift. So you'll get a very bright image. So generally, whenever we are wanting to turn on Doppler, if the angle is parallel to the flow of blood, what really happens is this angle becomes 0 or 180. So that makes a cos of 0 or cos of 180 will be 1 or minus 1. Essentially, giving us a good signal. While if we have this angle being 90, because our probe is perpendicular to the blood flow, we will get no signal absolutely. Ideally, we should keep the Doppler angle to less than 60 degrees
Sangamitra, I think she got disconnected.
Yeah, even I am not getting, sir. I will just call her, sir. Kindly
Yeah.
wait. She is trying to reconnect, sir.
Okay.
We can pause the recording if it is till the time she reconnects.
Purva,
Um,
can you make it a little bit faster because we are running out of time and still one presentation left?
sure, sir. I can
Yeah,
do that.
please go ahead.
So moving on to color Doppler, the basic thing that you should remember here is BART. Blue means that the signal is moving away from the transducer. B for blue, A for away, while RT is towards the transducer, we get a red signal. So now this is basically an image where if we put the probe perpendicular to the vessel, we will see no signal, while if it is with the transducer aiming away from the vessel, we'll get a blue signal, while if it is aiming towards the vessel, we'll get a red signal. The second thing that in case we are not able to get any signal with the color Doppler, we must check on the color power Doppler. Color power Doppler will not tell you where the blood is going, but it is only going to tell you that there is a structure with blood or any motion within it. It is significantly more sensitive than color Doppler, and it should be used in any obese patient or elderly patient, or in a small or deep vessel, or in any vessel where there is low flow there. Now, one advantage here is that there is no aliasing. That will be discussed in the artifacts. The second part of this presentation would be the needling strategy, the needle visibility, and its safety. So most of what I'm going to tell you is something that you already know, so I can probably pace through this part. So the axis of scanning can be transverse versus longitudinal. Transverse, when you're scanning, you're going to see the nerve as a round structure, and so as even the vessel. While the longitudinal scan, you're scanning parallel to the length of the vessel, so it's going to appear longitudinal in nature. Regarding transducer orientation, there is no fixed rule per se, but we have an orientation marker on the screen and the transducer. You can sync them or to keep them to the right of the patient or keep them cephalad when we are scanning any structure. These are probably more basic nomenclatures, but to each is their own. Axis of intervention, very important to know when we are needling. In plane approach, where the needle is directly in flush under the beam of the ultrasound, so we can see the entire needle path. Prefer shallow insertion angles so that the entire needle length is visible, making your block very safe, where your needle shaft and your tip is visible. While the second would be out of plane, where the needle is visible as a small dot and it is lying perpendicular to the beam of the ultrasound. Here, we can never say conclusively if that is the tip or the shaft of the needle. It is just one point in the entire length of the needle. So we must be very careful when we are needling with an out of plane approach. We can use, probably a jiggling maneuver to see where we are, or dynamically move the needle while we're moving the probe, or use hydrodissection to confirm whether that's the tip when we are going with an out of plane approach. So there are certain techniques to enhance the needle visibility. They can be either from the probe front or from the needle adjunct. So first, we must always fix the geometry and the machine settings whenever we're doing that. Once we're done with that, then we must rely on other technology where we manipulate the probe. We can either tilt the probe, slide it, or toggle it in any way to get a better image or visualize our needle. Then secondly, we can use other imaging processing systems like harmonics and compounding to see if it makes the needle visualization better or worse. The third is where we can use echogenic needles and use also a function called beam steering to improve the visualization of shaft and needle tip. Whenever in doubt, use color Doppler and localize the tip before you move forward so as to avoid any injury to any vessel. Now, to make your ultrasound nerve block even safer, you use the ultrasound, a nerve stimulation, and you use an injection pressure. So you go for triple monitoring. The whole goal is to make your nerve block extremely safe. So I will just discuss this, that whenever we want to visualize any nerve, you can slide the probe to move over to your anatomy. Once you've done that, you will only tilt to explore through that anatomy. You can rock your probe from side to side to optimize the beam and the target alignment. Rotate your probe if you are having any problem with orientation of the needle to your ultrasound probe, and compress only when you want to confirm if that structure is compressible, like a vein or an artery, which wouldn't be. Again, when you are scanning, always check for anisotropy. It is so prevalent when we are scanning our sciatic nerve that sometimes we just suddenly miss it when we tilt our probe. So we need to basically have our angle of inclination completely perpendicular to the structure that we are scanning. A perpendicular beam would always give us a bright, well-defined structure, while an oblique beam at any angle is going to either make the structure completely disappear or make it look hypoechoic or just not in its natural form. This is the same image where if you scan it perpendicular, you'll see a bright image, while if you scan it at an angle, it'll appear slightly distorted. Next, so once you're done with settling your probe, you move on to kind of changing your needle. You can use an echogenic needle. So echogenic needles change how the shaft will reflect the sound. They're especially useful when you use steep angles to perform any ultrasound nerve block, because the normal needle that you're going to be using will probably disappear because of anisotropy, while these would allow scatter, and when you activate beam steering in your ultrasound machine, you will be able to see the echogenic needles better. So we have four types of needles here. The first one here in A is the polymer coated echogenic needle. These needles basically form a sheet of microbubbles along their surface when they're passing through that tissue. So they will increase the acoustic impedance and increase the echogenicity. Along with that, this polymer gives us another advantage, that it acts as an electrical insulator. The second is going to be certain grooves that have been made into the tip of the needle. While the third one is that we have micro reflectors that are embedded within the needle material. The one on the top here has also got these slight micro reflectors. This is the needle that you have by Pahung. We have a very beautiful view of this needle when you're seeing it. More than the needle shaft, the needle tip visibility is a lot more important to us. So you can make the needle tip visibility better by firstly always having your bevel up, because when you do have your bevel up, that is essentially making your needle into a single layer rather than having two reflective layers superimposing one over the other. So you can probably omit that small artifact from the tip. Second is that you will have certain grooves or notches at the tip, and they will reflect your ultrasound beam to your ultrasound probe a lot better. There are newer experimental technologies like the piezoelectric sensors or actuators that are being installed on the needle tip, and they are still under review, might come up in the future. In this diagram, if you see, if you have your needle completely perpendicular to the ultrasound probe, you will have maximum reflection. So now when you do have it at an angle, the reflected wave is going to disappear because it is essentially getting reflected away from the area, from the probe, thereby not coming into the field of view of the image. So one way of improving that is using beam steering, where the beam is only being given out at an angle to the needle, which is diagram C, and thereby that is going to be perpendicular to the needle and give out an image. While if you improve this further by making notches or improving the echogenicity, you will definitely be able to see your needle when needling in a steep angle also. There is another software enhanced of hypodermic needle. It is called needle profiling in our Sonosite. It has multiple different names in with different companies. So it basically superimposes a frame onto the needle here and can improve your needle visualization at steep angles. So you need to select just the area where you're going to needle from, and then you'll be able to see your needle better. So whenever you are doing your needling, you must always have your bevel up, always visualize the tip, use localization whenever in doubt, use Doppler to delineate structures, and always use tactile feedback. So once you hit a facial layer, pierce through it, just immediately stop. Imaging can be very challenging in a certain set of patients, like the elderly patients, primarily because they have a loss of nerve muscle contrast. And when that does happen, you need to improve your imaging by turning on tissue harmonic imaging, compound imaging, and dynamic range, because you want to improve the contrast so as to delineate the nerve from the muscle better. The second set of patients that do pose a challenge are obese patients. They have excess adipose tissue, which increases attenuation, scatter, and there is a larger depth to the target structure. So you can use a low frequency transducer and decrease your dynamic range, use a narrow sector width whenever possible, and use probe compression to reduce the depth to the target structure. You can even activate the speckle reduction filter, reduce noise so that you have no other queries while performing the block. We have other emerging assistive technologies. We have AI. So primarily the most important function currently of AI is where it uses color overlays. So basically, if you do have any commonly performed block, the AI system in like the GE machine will have a yellow color that it will place over the nerve structures, thereby telling you that you've correctly identified the structure while also labeling the key structures in the nerve block. But AI is still getting, there are a lot of studies going on it, and evidence on patient level outcomes is still limited. This is an AI generated image, uh, kind of summarizing everything that I have said, that we first go ahead and set up our machine, optimize the machine, then go ahead and check for any structures that may hamper or make our block unsafe, like any vessel in the plane of needling. Second is to strategize, where you decide whether you want to go in plane or out of plane, depending on what anatomy you visualize. Always monitor the LA spread and the needle while it's going through. Use adjuncts like nerve stimulators, injection pressures, and AI overlays in case you find any nerve block challenging. This is again the same uh, diagram depicting the same things. Thank you.
Thank you, Dr. Purva. Dr. Soumya, please share your slides.
Hello.
Yes, Soumya, please go ahead.
I'll start, ma'am.
Yes, please.
Good evening. Today I'm going to be talking about ultrasound artifacts. So what are ultrasound artifacts? One second, ma'am. Okay. So ultrasound artifacts are any features in an image that is not true or accurate to one-on-one depiction of the target being imaged. So artifact can be a structure that appears in the image but it is not present anatomically, or it can be a structure which is present anatomically but may be missing in the image. Ultrasound artifact may also be structures that are present but are incorrect in location, size, or brightness. So ultrasound display has it relies on few presumptions. The presumptions are: the echoes detected originate from within the main ultrasound beam. The echoes return to the transducer after a single reflection. That the depth of an object is directly related to the time for an ultrasound pulse to return to the transducer. The speed of sound in human tissue is constant. The sound beam and its echo travels in a straight path. The acoustic energy in an ultrasound field is uniformly attenuated. Okay. One. But in clinical sonography, these assumptions are often not maintained. When this occurs, echoes may be displayed erroneously and perceived as artifacts that arise secondary to errors. For coming to beam width artifact, the ultrasound beam, which has already been discussed, that when the ultrasound beam, it is not uniform with depth. The main beam leaves the transducer with the same width as it, and then it narrows near the near field, and then again it widens when it reaches the far field. So the beam width artifact occurs when a reflective object located in the widened ultrasound beam after the focal zone produces false detectable echoes that appear to overlap the structure of interest. How do you solve this? By adjusting the focal zone to the depth level of interest, by placing the transducer at the center of the object being studied, by increasing the probe frequency to create a narrower focal zone. So,
Yeah. So in the first image, we can see that the object of interest is away from the focal zone, due to which the resolution is bad and there is overlapping of images which is seen. But in the second image, when the area of interest is in the focal zone, the resolution is better and there is no overlapping of images seen. So this is an example of the urinary bladder, where you can see few speckles, inside the urinary bladder, which is because of beam width artifact. But when we adjust the focal zone, what happens is the intravesicular echoes are eliminated. Coming to side lobe artifact, the energy within the ultrasound beam exists as several side lobes radiating at a number of angles from a central lobe. Echoes are generated by these side lobes in addition to the main lobe, but all the returning echoes are assumed by the transducer to have arisen from the central axis of the main lobe. Side lobe echoes will therefore be misregistered in the display. So this is the image here is showing the central main focal zone and with the side lobes present all around it, due to which there is superimposition of the artifacts onto the structures of interest, due to which in this image we can see a septated cyst, but in real the cyst is not septated. Coming to reverberation artifact, false echoes due to repeated reflection between two interfaces with a high acoustic impedance mismatch. Some of the energy in the returned echo is reflected at the transducer phase and returned to the reflecting interfaces as if it was a weak transmitted pulse, returning as a second echo. As the time taken for the second echo to arrive is twice that taken by the depth and so on, this sequence of reflection and transmission can occur many times. The reverberation echoes will be equally spaced. These reverberation echoes will be strong because of the high acoustic mismatch. How do you rectify it? You can rectify by increasing the amount of gel used to reduce the acoustic mismatch. Use a standoff pad, reduce the gain, move the position of the transducer. So in the first image, we can see reverberation artifact which are seen in the lungs. There is reverberation between the transducer and the pleura. So we can see A lines in the lungs, which is because of reverberation artifact. And in the second image, we can see reverberation due to reflection of waves in the internal diameter, in the internal surface of the needle. Coming to comet tail artifact, it is a form of reverberation in which the two reflective surfaces and thus sequential echoes are closely spaced. On the display, the sequential echoes may be so close together that individual signals are not perceivable. In addition, the later echoes may have decreased amplitude secondary to attenuation. This is displayed as decreased width. The result is an artifact caused by the principle of reverberation, but with a triangular tapered shape. So in this image, we can see comet tail artifact, which is seen inside the gallbladder. It is because of the Rokitansky-Ashkoff sinuses. This, if you see a comet tail in the gallbladder, it is diagnostic of adenomyomatosis. The next artifact is ring down artifact. A ring down is an ultrasound artifact that appears as a solid streak or a series of parallel bands radiating away from abdominal gas collections. The ring down artifact originates from the center of a cluster of 4 bubbles, bubble tetrahedron, 3 on top and 1 nestled beneath. Entrapped between the bubbles is a horn or bulb-shaped fluid collection that we theorize emits a continuous sound wave back to the transducer when struck by an ultrasound pulse. Electronic processing by the scanner converts this continuous sound wave into the series of bands seen in the ring down artifact. So ring down artifact is seen when there is 4 air bubbles in a tetrahedron structure. in a tetrahedron structure, and there is fluid collection in between. So this fluid collection will give a continuous step ladder kind of appearance, which is known as the cometal artifact. Coming to mirror image artifact. Mirror image artifact in sonography is seen when there is a highly reflective surface, example the diaphragm, in the path of the primary beam. The primary beam reflects from such a surface, like the diaphragm, but instead of directly being received by the transducer, it encounters another structure, like a nodular lesion in its path, and is reflected back to the highly reflective surface. It then again reflects back towards the transducer. The ultrasound machine makes a false assumption that the returning echo has been reflected once, and hence the delayed echoes are judged as if being written from a deeper structure, thus giving a mirror artifact on the other side of the reflective surface. So in this image, we can see that the liver lesion, it looks like it is present in the thorax, but it is actually a mirror image of liver over the diaphragm. Coming to speckle artifact. Speckle artifact may be encountered in ultrasound. It is caused by the scattering of waves from the surface of small structures within a certain tissue. The artifact produces a textured appearance. Because speckle can make it harder to distinguish soft tissue differences, modern ultrasound machines reduce these speckles through various techniques known as despeckling. So the first image where there are a lot of scattering of the image because of rough surface. This can be removed and a despeckled image can be produced by frequency compounding. Coming to double iota artifact. The double iota artifact is a relatively common ultrasound artifact resulting in an artifactual duplicated abdominal iota in the transverse plane. Knowledge of this artifact is important because there are potential differential diagnoses like aortic dissection. The physics behind this is the artifact is caused by the differential refraction of the ultrasound beam while passing through the relatively echogenic rectus abdominis muscle and the comparatively hypoechoic fatty tissue underneath it. This forms a acoustic prism effect. The artifact is primarily seen in curvilinear transducers. So partially or less commonly, complete duplicated double barrel appearance of the abdominal aorta in the transverse plane is characterized, which also affects color Doppler imaging. The artifact can be diminished by changing the angle of insonation in a way that the beam no longer passes through the acoustic prism, or if you rotate the probe in the sagittal plane, it gives similar result. So this is an image showing double iota artifact. The next artifact is speed displacement artifact. Ultrasound image processing assumes a constant speed of sound in human tissues of 1540 meter per second. But the ultrasound beam may encounter variety of material and it has various, the speed varies in each of these materials. So because of this, the sound travels through materials with a velocity significantly slower than that assumed. Therefore, the returning echo will take longer to return to the transducer. The image processor assumes that the length of time is related only to the distance traveled by the echo. The echoes are thus displayed deeper on the image than they are really, and this is known as speed displacement artifact. So in this image of the liver parenchyma, due to the presence of focal fat tissue, the speed of sound is delayed. So which occurs as the diaphragm is displaced down. Next, coming to refraction artifact. Refraction artifact can occur when a transmitted ultrasound pulse strikes an interface at a non-perpendicular angle. The difference in propagation speed between the two tissues can cause refraction to occur. Should the refracted incident sound wave strike a reflector and cause an echo to return to the transducer, this may be displayed at an incorrect location as the transducer assumes all echoes have traveled along a direct path. So this is an image showing the refraction. So due to the refraction of the image, of the waves, it appears there are two arteries in this image. This is because of refraction which occurs. Refraction artifact should resolve if the transducer is moved in such a way that the incident pulse is perpendicular to the interface. Coming to edge shadowing, a combination of refraction and reflection occurring at the edge of rounded structures will result in edge shadowing artifact. The outer part of the beam will be totally reflected, but the remainder of the beam passes through the rounded structure and is refracted. This combination of reflection and refraction at the edges results in a thin strip of tissue behind the edge not being insulated and causes a shadow. So whatever waves are refracted are not picked up by the transducer, which shows a edge shadow in this image. This is an image of thyroid nodule showing edge shadowing. Coming to acoustic enhancement artifact, this artifact appears as a localized area of increased echo amplitude behind an area of low attenuation. On a scan, it will appear as an area of increased brightness and can completely be seen distal to fluid-filled structures like the urinary bladder, gallbladder, or a cyst. It is caused by the low level of attenuation of the beam as it passes through fluid relative to the greater attenuation of the beam in the adjacent more solid tissues. So in this image, we can see a fluid-filled cyst in the liver, which is showing acoustic enhancement distal to it. Coming to acoustic shadowing, this appears as an area of low amplitude echoes behind an area of strongly attenuating tissue. It is caused by severe attenuation of the beam at an interface, resulting in a very little sound being transmitted beyond. The attenuation can be due to either absorption or reflection of the sound waves or both. So in this image, we can see the stones in the gallbladder are causing acoustic shadowing. And in the next image, this is a foreign body present in the soft tissue, which causes acoustic shadowing behind it. The next topic is anisotropy. Anisotropy is an artifact encountered in ultrasound, notably in muscles and tendons during a musculoskeletal ultrasound. When the ultrasound beam is incident, the organized fibrils may reflect a majority of the insonating sound beam in a direction away from the transducer. When this occurs, the transducer does not receive the returning echo and assumes that the insonated area should be hypoechoic. This depends on the angle of insonating beam. The maximum return echoes occur when the ultrasound beam is perpendicular to the tendon. If the artifact causes a normal tendon to appear hypoechoic, it can be misdiagnosed as tendinosis or tear. So in this image, yeah, in this video, you can see when you change the angulation of the probe, the muscle fibrils can appear hyper or hypoechoic. It appears hyperechoic when it is perpendicular and hypoechoic when it is less than 90 degrees. The next artifact is bayonet artifact. The delay in return of echoes from tissues that has slower transmission speed, coupled with the processor's assumption that the speed of ultrasound is constant. It causes the processor to interpret these later returning echoes from the tip of the needle as being from a deeper structure and thus giving a bayoneted appearance. If the tip is traveling through tissue that has faster transmission speed, then the bayoneted portion will appear closer to the transducer. So bayoneting artifact is basically the presence of It is basically a presence of break in the needle. There is a bend in the needle. This occurs because when the needle passes from one soft tissue to another with different like a speed of propagation of sound, there is refraction which occurs and it causes break in the needle. Next, coming to artifacts which are seen on Doppler ultrasound. Blooming artifact. Blooming or color bleed artifact occurs when the color signal indicating blood flow extends beyond its true boundaries, spreading into adjacent regions with no actual blood flow. Blooming occurs because the spatial resolution of color Doppler is lower than grayscale ultrasound. It can be exaggerated by inappropriately high color gain. It is important to be aware as it may obscure partial occlusions such as thrombi, resulting in misdiagnosis. It can be avoided by lowering the color gain until the bleed of signal outside of the vessels disappear. So in this image, you can see that yeah. So in this video, we can see that the colored, the Doppler imaging is outside the boundary of the vessel. So this shows, this is known as blooming artifact. Next, coming to color buoy artifact. The color buoy or tissue vibration artifact is a type of color Doppler ultrasound artifact which results in color signal overflowing to the perivascular tissues, most often caused by stenosis, AV fistulas, or shunts. The physics behind this is turbulent flow causes vibration of the vessel wall and perivascular soft tissues, resulting in a detectable Doppler shift, which typically results in a mixture of red and blue speckles. The color buoy is a beneficial artifact that helps with localizing areas of critical stenosis or turbulent flow due to other reasons. So you can see color. In this image, we can see color buoy artifact which occurs post stenosis of the vessel, right renal artery, causing because of the turbulent flow. Next, twinkling artifact. Twinkling artifact is seen with color flow Doppler ultrasound. It occurs as a focus of alternating colors on Doppler signal behind a reflective object, such as a calculus or air, which gives the appearance of turbulent blood flow. The underlying mechanism of this artifact is thought to be as a result of inherent noise within the ultrasound scanner, jitter within the Doppler electronics. Twinkling artifact is more sensitive for detecting small stones like urolithiasis or polylithiasis than as acoustic shadowing. So in this image, we can see there is twinkling artifact which is seen behind the this urinary bladder with a calculi. So you can see a twinkling artifact wherever the calculi is present. Next, coming to aliasing phenomena. Aliasing is a phenomena inherent to Doppler modalities which utilize intermittent sampling, in which an insufficient sampling rate results in an inability to record direction and velocity accurately. Unlike continuous wave Doppler, pulse wave and color flow Doppler modalities alternate between rapid emission of ultrasound waves at a rate termed the pulse repetitive frequency. The time an ultrasound wave travels, given a constant speed in soft tissue, will correspond to the distance traveled. Pulsed wave Doppler and color flow Doppler operate on this presumption. When a location of interest is designated, the ultrasound machine will only record returning echoes during an interval that corresponds to the time necessary for wave egress and return along a linear path. If Doppler shifts occur at a frequency exceeding the maximum pulse interval, that is 1 by pulse repetitive frequency, detected phase shifts will be calculated based on incorrect assumptions. The Nyquist frequency is the maximum signal frequency that can be accurately captured and reconstructed from digital sampling, defined as half the sampling rate, that is pulse frequency repetition divided by 2, and is crucial for avoiding aliasing, distortion where high frequency appear as lower ones. To perfectly reproduce a signal, the sampling rate must be at least twice the highest frequency in the signal, a principle known as Nyquist-Shannon sampling theorem. Factors such as higher velocities of target structures and increasing depth of the region of interest insonated will result in aliasing and consequent range ambiguity. Other causes can be use of higher frequency transducers, inappropriate angle of insonation, large sampling volume. So this is an image showing aliasing where a higher frequency is displayed on the lower, displayed at the lower value because it crosses the Nyquist limit. So over here we can see aliasing artifact which is seen because of stenosis of the vessel, which was later confirmed on an MRI. So how do you eliminate the effect of aliasing? You change the Nyquist limit. Select a transducer with a lower frequency. This shrinks the spectrum. Use continuous wave Doppler. Select a new view so that the angle is further away from 0 and closer to 90 degree. This again shrinks the spectrum. Baseline shift. This is basically it is basically for the appearance only. Decreasing the pulse repetitive period to increase the pulse repetitive frequency. So this is an image showing aliasing. So how can you correct it? By increasing the scale or by increasing the baseline so that the higher frequencies can be displayed. Coming to the last artifact, electrical interference artifact. Electrical interference artifact is an ultrasound artifact usually caused by the ultrasound machine being too close to unshielded electrical equipment. The disturbance appears as an arc-like moving bands in the ultrasound image. While the presence of electrical equipment like unshielded ventilators near the ultrasound machine may cause this artifact because of external electronic signals, it can also occur because of ultrasound probe malfunction. So this is an image where you can see an arc-shaped disturbance, which is because of electric transducer, either the transducer issue or any other electrical equipment near the ultrasound. Thank you.
Thank you, Dr. Soumya. I will request all the presenters to keep their videos on. And Hetal sir, shall we go ahead with the discussion?
Yes, please. I think all three presenters presented very nicely. They are extensive presentations, and these are very important for theory exams, because in every theory exam you will find a question from these three presentations. So it is important to learn, though they are boring, like physics is boring, but you should be clear about ultrasound basics so that you get at least 10 marks in exam, first 10 marks in the exam. Over to you, Sangamitra, and all moderators. Anshuman, Dilip, and
Pramod sir.
Pramod sir.
Yeah. Can I ask any fellow to describe the aliasing effect? I mean, other than the three presenters, anybody else will describe the aliasing effect? Hello. Okay, so any presenter can describe it again. We can discuss that. Yes, Purva?
Aliasing effect is primarily basically seen in Doppler ultrasound, and
Anyone
it is
wants to
basically resulting in image. It is basically because of misunderstood velocity when we encounter a vessel with very high velocity.
Okay. Yeah, please continue.
What really happens is that in all ultrasound machines, when we do kind of have a Doppler effect, we have certain set limit, which is called as a Nyquist limit. When the Doppler effect crosses over that Nyquist effect, it basically has a wraparound effect. That wraparound effect means that beyond that set limit, whatever we have, in case of a color Doppler, it will show a mix of signals with the red and blue mixing together to form a new color. While in a pulse wave Doppler, we will have the edge beyond the Nyquist limit as a break, and it will show as a negative effect, which will be wrapped around and appear as a separate wave on the bottom. And that would basically result in an aliasing effect.
Yeah, so we'll be having a red color for the positive.
It can be reduced if we increase the pulse.
Yeah, and blue color for the negative one. So you cannot have red and blue in the same vessel. So whatever blue area was because of the high velocity, right? So aliasing effect was happening there at that blue areas, and that image shows that after MRI they could find out the stenosis there. Another thing is when you can see the aliasing effect is when you are scanning at the deeper levels. Okay, so what happens when you are scanning at the deeper levels? Your pulse repetition period increases, and obviously, as it is reciprocal of pulse repetition frequency, it decreases. Okay, so with decreases pulse repetition frequency, it has to be at least equal or twice the Nyquist limit. Okay, so as it decreases, aliasing effect artifact can be seen. So if you are these are the two things. One can be the diagnostic, like stenosis and all that. If you are having any vessel stenosis, and aliasing can detect it, and the other one is not useful for diagnostic or something, but it is like troublesome. But if you are doing it as a deeper levels, then again aliasing can happen. Any questions? Anybody want to ask any questions?
I think during artifact presentation, Soumya described all the artifacts nicely. But what are the important artifacts while doing regional anesthesia practice?
Reverberation artifacts, sir, acoustic shadowing and acoustic enhancement, and double mirror artifact. I think these are the other artifacts.
Mirror artifact can be seen with the subclavian artery when you are doing the
Clavin.
supraclavicular brachial plexus block. Okay, the
Yes.
rib is highly reflective object, and with the subclavian artery above that, you can get the mirror image, and exactly you can get the subclavian artery. And if you are putting a color Doppler in that, that can also be seen with a less effect in the background.
Yes, sir. And anisotropy also, which was already described for sciatic nerve, when it's at 90 degree, the image is well observed. Otherwise, the image clarity.
Then bayonet.
Oh, yeah, sir. Bayoneting artifact.
And what are the important artifacts while doing focus examination?
Focus exam.
Especially lung ultrasound.
Yes, sir. A lines can be seen due to reverberation.
What about ring down effect artifact? Ring down artifact in focus?
Yes, sir.
What is that?
When there is four.
Yeah, that is fine. I mean, that is the physics, but when do you see it in focus, in lungs?
Focus. Pleural effusion, sir?
Pulmonary edema. Pulmonary edema. B lines. B lines is nothing but the ring down effect artifact.
Okay, sir.
Right?
Okay.
Yeah, so that is the B lines.
Okay, sir.
The bayonet effect is more, more distinct with the, if you are using the quantiplex needle. They are the bigger needles with wider, lumen and all that. So that effect is more obviously seen with the bayonet, with this thing, quantiplex needles. Even sphenoiplex needle are also, you can see that. But being the bigger, wider needle and this thing, bigger lumen, you see that bayoneted limit, and even reverberation effects. Both are seen very nicely with the quantiplex needle.
Okay, sir.
So, question to anyone of you can answer. When you are taking any patient to the OT for ultrasound guided block, so how will you start the machine, and what setting will you go while giving? Suppose I am giving supraclavicular block. So, how will you set the machine? Anyone from?
So once we take.
Yeah. Yes, Priya. Purva.
So when we're planning a supraclavicular brachial plexus block, suppose we are doing the brachial plexus block on the right side of the patient. So first we will position the patient with the left head turned to the left side, and the supraclavicular fossa would be kept exposed and visible along with certain area around it to maintain a sterile field. Keep our ultrasound machine If we are performing the supraclavicular brachial block standing on the right side of the patient, then the ultrasound machine will be placed opposite in the same
Dr.
visual
Purva,
axis.
Dr.
So
Dr. Purva,
basically against the shoulder of the patient.
Dr. Purva,
Yes, Anshuman.
Dr.
Yes,
Purva,
sir.
Dr. Hetal's question was very
Yes, sir.
simple. When you get a question, first understand what the examiner is asking you. His question was, when you get a patient for a supraclavicular brachial plexus block, what are the modalities that you are going to fix in an ultrasound machine? So when you open the ultrasound machine, you need to say which machine you have, what are the modalities you are checking, which probe you are picking up, what is the whether you're putting it in the MSK mode, in the NER mode, what is the depth you're setting. All these things probably Dr. Hital wanted to ask, if I'm not wrong.
Yeah, you can start with probe selection, then machine setting.
Yes, yes.
So I would pick up a linear high frequency transducer because it's a fairly superficial block. Along with that, I would keep, when I turn it on, I would keep the preset to depend in my machine, which when I use a Sonosite PX, I find the MSK setting to be better rather than the nerve setting, because nerve makes it very high in contrast. So I basically select the MSK setting, select the depth to about 3 centimeters to start with when I'm starting to scan, and then reduce when I do have the area of interest to basically about 2.5 centimeters if the patient is lean. And if the structure is visible, I will then also have the tissue harmonic imaging on in most of the time that I do have. Along with that, I would then adjust the gain once I have the image acquired. Since it's fairly superficial, I don't generally use time gain compensation. I mostly go for overall gain and acquire the image accordingly.
Yeah. So how will it will be different for sciatic nerve block?
So someone
So
other than
sciatic
Purva
nerve
can speak.
block being
No, I think someone other than Purva can. Prerna, you can come in now. You can use this.
For a supraclavicular block, I'd also use the Doppler to see if there is
Not for the for the sciatic nerve. Dr. Hital is asking for sciatic nerve.
Right, sir. So for the sciatic, first I would choose a curvilinear probe, considering it is a deeper nerve block. So I'll use the curvilinear probe, and I will set to preset to MSK, and I will start scanning from the gluteal region. So if it is in the gluteal region, I would go ahead with a low frequency probe. But if I was giving the sciatic nerve block in the popliteal region, then a high frequency probe can also be used. And I will adjust the gain settings. If it is in the popliteal region, I will turn on the Doppler, make sure I'm away from the popliteal artery, identify the two structures, adjust my gain settings, and adjust my depth to about 2.53 centimeter, depending on the build of the patient. And I will go ahead in an in-plane approach.
So what about subgluteal sciatic?
Subgluteal sciatic would be done with the curvilinear probe, sir. I will identify the structures, the sacral hiatus and the ischial tuberosity. I will identify the bony structures, increase the depth.
Yeah, so I'm asking about machine setting only, not about the nerve block.
Yes, sir. So I will increase the depth to 6 centimeters, 6.5 centimeters, and keep the probe at 90 degrees where the sciatic nerve is, where it appears most hyperechoic, and adjust the gain to.
Purva, you want to add anything? Purva?
In case I'm
any of the
having
fellow can add anything.
difficulty,
Purva, you are saying something. Please go ahead.
because in case it's relatively deeper and the patient's habitus is more than I would like to use time gain compensation to now make the distal part a little brighter so that I'll have better nerve visualization here. So when compared to the supraclavicular block, I would then use the time gain compensation here, and that would be a differentiating factor.
Yeah. Soumya, any artifact you encountered while giving popliteal cytic block?
Anisotropy, sir.
Yes. Anything else?
No.
So how will you tackle anisotropy?
We can also see bionetting
Yes,
artifact.
very good. Excellent. So how will you tackle that? Anisotropy especially.
Anisotropy, we have to make sure that the probe is at 90 degrees to the structure, sir. So we have to tilt the probe or slide the probe to get an image like at 90 degree to the structure.
Okay, good.
Then mainly and sliding the probe.
So I mean, insonation angle is important to get the best image and to prevent the anisotropy artifact, right?
Yes, sir.
Anshuman, over to you.
So there are a few things just I wanted to say. First thing is that when a topic is given to you, the topic, your plan is that, my idea is that every fellow should read these topics. And the presentation should be in a crisp and precise manner where the person go back with some knowledge. So the time is very important. Our attention span is not more than 20 minutes. And if we make the same slides in a tabular manner, if we make it point wise, it is very easy to remember these things and reproduce also. Remember, when you're making these PPTs, this can act also as your final examination points, questions also. You can add to these PPTs and you can also perform during your exams. One point you should always remember is that when the topic is this, machine and ultrasound and physics and all those things, it's what is not important is remembering all the names, or maybe you may not remember all the names when you are attending for the exam. But you should be knowing how to apply those things and come out of it. That is one thing. Number two is that he should always remember it. Ultrasound is an operator-dependent procedure, so it gives you a thin slice. Unlike in CT or MRI, where you get a three-dimensional image reconstruction, in ultrasound you do not get that. So how to angulate, how to do all these maneuverings where you can see the needles is very important that you need to see. So what is SNP? Anyone using sonocyte machines? U3, anyone of U3 using sonocyte machines?
Yeah. SNP stands for steep needle profiling, sir.
So how does it benefit and how you do it?
If we are trying to reach a deeper structure with our needle, and if the angle is more, if the needle is not parallel to our probe, then normally we will not be able to visualize this needle. But if we switch on SNP, then so there are three profiles, A, B, and C, depending on how steep we have to need it. So so based on how much is the degree of angulation of our needle, SNP will help in enhancing the visualization of the needle when we are trying to needle a deeper structure.
So when you get a question, how to use SNP, how to describe, you start speaking and then you realize that there are three parts. Then you put it into tables. So that is easier for you to remember also, and everyone for you to understand. So did you speak about Doppler? What is power Doppler and how it is different from normal Doppler? Did anyone speak about power Doppler?
Yes, sir, I did. I briefly.
And how is it different from the normal Doppler?
So color Doppler is telling us whether the flow is towards the probe or away from the probe, while power Doppler is only amplifying a flow. It is not telling you the direction of the flow. So it will show you one color change to depict in a low velocity vessel that some form of motion is present within the vessel, while it is not going to give you the direction of the flow. But it will
give me an example of a power Doppler. Very good, very nice. You have done it, Penny. You get the correct answer. Give an example where you use power Doppler and where you use a color Doppler.
So when you have
anyone other than Purva can also answer. Anyone other than when Purva must have prepared it well.
Uterine arteries, we will see using a power Doppler to see if there is systolic and diastolic flow. And
Uterine artery.
yes, while doing an obstetric scan, there's systolic and diastolic flow. So the absence of diastolic.
In regional anesthesia, where you get a small vessel that you want to see. When you do a dorsal penile nerve block, so you get the vessels are very thin in most very thin patients, very thin kids, like into 2 days old. So there, these PWs help a lot. You can find the vessels because the vessels and nerves are very close to each other. And if you get a good image of the vessel, at least you know where not to put the needle. Okay. And one artifact that is very common that Soumeshri, this question is for you. When you're using focus for spine, for difficult spine,
Yeah.
do you get any artifacts in spine that you need to take care of when you are doing for a difficult spine? Actually, my only reason was that when I was listening to your talk, the talk was more on completely on the RA. That's good part, most part of the focus. But I think we missed the spine part a bit also.
Okay.
So my suggestion is that spine is the bread and butter of most of the anesthetists. So we should also try to use that in our normal practice and part of our focus also.
Okay, sir.
So there are many artifacts that you will be seeing in spine part also when you're using a difficult spine. So there are a lot of angles. You need to study that part also.
I'll read up
Fine.
about it.
Otherwise, so this is not for you, it's for everybody. So when you are getting a topic, my suggestion would be that when we have the whole list for the year. So just because Prerna is presenting the ultrasound, the physics of ultrasound, doesn't mean that rest won't practice or read about that one. You can also make your own PPTs and you can make it in own version. So you know what extras he is adding or what Purva is adding or what Soumeshri is adding for that thing. So that will help each of you to increase your knowledge base. And the whole idea is to discussion on this part. Otherwise, very nicely done. Thank you. Thank you so much. Thank you.
Dilip, are you there?
Yeah. So, so I'm a pediatric anesthesiologist. So, two questions I would like to ask. One thing to Purva. For example, you are doing a neonate, and then which probe you will use for a caudal block? Because it is very important in pediatrics because the probes, everything is a little bit different. So, which probe you will use?
So I have two options. One, I can either go for a linear probe with a small footprint, or which can translate into a hockey stick probe, or a linear probe itself.
Perfect. And the ergonomics, how you will keeping the ultrasound?
So the child will be lying lateral. So I will be holding the probe against the body of the child, and I'll be standing behind the child while the ultrasound machine will be right in front of me.
Good. So just in front of you, so that it becomes very easy to manage. Another important thing, I think, so it would have been great the needling techniques, instead of showing, it would have been shown actually. So it would have been easier for others to understand that, okay, this is how you should be maneuvering the needle. So that would have been benefited much more. Yeah.
Dr. Pramod sir, anything from you? Sir, you are muted.
Hello.
Yeah.
Regarding that aliasing effect, again, like we are just discussing about the color Doppler, pulse wave Doppler, and continuous Doppler. So that aliasing effect, you don't get it with the continuous Doppler, okay? Because there is no, listening time for the continuous wave Doppler. So you don't get that aliasing effect with that, but you can get it with the color Doppler or pulse wave Doppler, okay? Can anybody discuss the pulse wave Doppler, how it is different from the color Doppler? Yes, Purva?
In pulse wave Doppler, we basically place a gate within a vessel, and then we have a two-dimensional waveform formed by the like along the x and y axis, which will show us the motion in a graphical form. That would be the pulse wave Doppler.
Okay. Fine.
Any questions from fellows? Dr. Vipin, any comments from you? I think. Sangamitra?
No, sir, they have very well covered it.
Yeah, sure. Shall we close the session?
Right, sir. I think the session will actually has exceeded, so I will not be able to play the quiz also today.
Okay, that's fine. We can
Yeah,
start from
yeah,
next
yeah.
time.
Right, sir. Right.
So there will be homework for all the fellows. I will post it